The medication I chose to go over for this presentation is cyclosporine. Cyclosporine is used to prevent kidney transplant rejection. It is commonly used alone or with another medication called methotrexate. It can also be used to treat rheumatoid arthritis, psoriasis, and Crohn's disease. Cyclosporine can reduce the ability of accessory cells to produce interleukins. It can also decrease replication of helper and killer T cells. It has very high specificity and effectiveness. There's an improved success rate for organ transplants. The long-term efficacy of cyclosporine. The safety of long-term immunosuppression with cyclosporine is not well understood. Using this drug may cause progressive toxic nephropathy. It can preserve renal function because it prevents rejection. Cyclosporine improves graft survival. Patients tend to have impaired renal function after this, though. Cyclosporine nephrotoxicity occurs in patients who have other transplants. When azathioprine is substituted for cyclosporine, the risk of rejection increases and renal function improves. Cyclosporine was discovered in the 1970s, and it wasn't used as an immunosuppressant drug until the early 1980s. It was the most successful anti-rejection drug at that time. It has improved the chance of survival for most transplant recipients. Cyclosporine is a cyclic endocapeptide, and it is also a calcineurin inhibitor. The mechanism of action, it's inhibition of the important phosphatase calcineurin, and it binds to proteins known as immunophilins, binds mainly to the cyclophilin A found within T cells. It also inhibits the mitogen-activated protein kinase, or MAPK pathway. It inhibits the JNK, or the MAPK8, and the P38, or MAPK14 pathways. The nephrotoxicity of cyclosporine. First experiences with cyclosporine nephrotoxicity were functional changes and reversible. These are recognized as acute CNI nephrotoxicity due to the vasoconstriction of the afferent arterioles. The reversible tubular dysfunction was a feature of acute CNI nephrotoxicity. It can induce imbalances in the vasodilator-vasoconstrictor ratio, which promotes renal vasoconstriction. Cyclosporine also, there's some other facts with it. The higher the blood concentrations of cyclosporine are associated with better long-term renal function. The patients who had a transplant who received higher doses had better renal function for the first 3 years after their transplantation. Patients with stable renal function are usually given lower doses to avert renal damage because they are, just like it says, stable at the time. Patients with declining renal function, meaning their GFR rates are going down, their creatinine is going up, those are given lower doses to minimize the toxicity. I found a chart that kind of showed how it inhibits the calcineurin, the mechanism of action. It just kind of shows how it flows into the cells and then stops and inhibits the certain proteins and what it binds to. And then here's another chart I found from Johns Hopkins, and it just talks about also the mechanism. It talks about the dose, and then some of the side effects. There are a lot of side effects if you take this medication. It can cause confusions, hallucinations, alopecia, some gingivitis disease, high blood pressure, high cholesterol, nausea, diarrhea, glucose intolerance. Like it talked about the nephrotoxicity, the increased renal function, can cause acne, and it could also cause people to get diabetes. And here are some of my references. Here's the other page. Thank you.